So if you look at literature and if you look at this article from Elizabeth Arndt, what was shown is that majority of the patients who come with a first-time patellar dislocation is in the second decade. And if you were to look at the demographics, boys are equally affected to girls. There is, even with a recurrent dislocation, there is not much of distribution difference as far as males versus females is concerned. What was important to note is what you heard in the previous talk, that majority of these patients do have trochlear dysplasia. And that's something that a lot of attention needs to be paid into. And the females tend to be having more trochlear dysplasia as compared to males. We all know about the de jure classification, where primarily you're looking at three types. You're looking at an objective patellar instability, a potential patellar instability, and a painful patellar syndrome. Wherein in the first type, you have a documented dislocation which is associated with the risk factors, and there is a painful knee. In the second type, you have the risk factors, but you don't have a dislocation, and there may be pain. And in the painful type, patient just presents with pain, does not have the risk factors or does not have a documented dislocation. Now, what was described by Sheetal Parekh in the skeletally immature was this classification, which divided into four types. You have the type 1, which is the first time dislocation. You have the type 2, which is a recurrent instability. The type 3 was a dislocatable patella, and the type 4 was a dislocated patella. Each was subdivided into a type A and type B, where a type 1 was with or without an osteochondral fracture. A type 2 was either a subluxation or a dislocation more than 2 times. A type 3 where there is a passive patellar dislocation in type A and a habitual patellar dislocation in type B, wherein the authors have defined habitual dislocation as dislocation of patella with every flexion and extension. Now, this is not the same as a voluntary patellar dislocator, where differential muscle patterning allows the patient to voluntarily dislocate the patella and relocate the patella. This is an involuntary dislocation which happens with every flexion extension. And lastly, you have the dislocated patella, whether it is a reducible or whether it is an irreducible type. Now, what is important to understand is your type 1 and type 2 classically will present with the adolescent type, the young adolescent type. It is the type 3 and type 4 who present with the younger ones, the skeletally immature, and higher likelihood that they are going to require surgery. So how do we effectively manage them? So let's look at a type 1, and 95% of patellar dislocations are associated with chondral lesions. You heard in the imaging and the screening how important it is to get your ideal x-rays and look for subtle signs. What typically happens is that when the patella dislocates, your medial restraints are going to be injured. The patella is going to move laterally. It is going to clip itself, the central ridge is going to clip itself against the highest point of the trochlea in case of a normal patella or a normal trochlea, and then that dislocates on the lateral side. Now, when you're trying to relocate, what is going to happen is that the medial facet then engages with the lateral facet of the trochlea, and when you try to do that forcefully, that results in an osteochondral defect where the medial facet is avulsed and it lands into the lateral gutter. And that is why it is important to scope these patients in the lateral gutter, not just the suprapatellar pouch or the medial and the lateral compartment, because you would want to find that fragment, and depending on that fragment, your management is going to change. So even on plain x-rays, you can see that you can not just see this is not a patellar shadow. On the lateral view, you can clearly see that this is that osteochondral fragment. And as would be required, an MRI is important, because an MRI is going to allow you to see, here you can see that the cartilage on the lateral facet is good, and then you have an absence of the cartilage, and this way here on the sagittal frame, you can see that osteochondral fragment lying behind the Hoffa's fat pad. You saw similar pictures in the previous talk, and this is what will happen when you go in for a formal approach. You're going to clean the cartilage edges to a stable margin, drill in holes. If it's a big fragment, you can use in headless screws, but in a pediatric population, you would want to avoid any metal work as much as possible. You pass in your vicryl sutures. You can use in a fibrin glue to coat that entire bed of that crater, and then you can refix the fragment using the vicryl sutures, because once the healing takes place, you really don't need to bother about it. You may or may not augment MPFL depending on the amount of instability that you have, but usually many times with a bony fragment, if it's a big fragment, all the medial structures would come in because it's an avulsion injury. If it's just a small osteochondral fragment, then you may have to consider this. Now, when you're looking at a type 2A or B, 88% patients are likely to have a recurrent dislocation, and there is a trend towards considering an MPFL reconstruction. But mind you, the principles of MPFL reconstruction in a skeletally immature is not the same as what it would be an adult. So you're not just looking at the Schott's point, because there is a high chance of a physeal injury. So what has been described? You have procedures where you have a distal to the physis, where it's an all epiphyseal type of reconstruction with a soft tissue graft, and it's mandatory to use the fluoroscopy, because without which you're invariably going to land up injuring the physis. What has also been described by Kevin Shea is that you can do the anatomy in the immature skeleton varies. So you can either have an attachment of MPFL proximal to the physis, or it might be distal to the physis. So if you have someone who's younger than 7 years, the attachment is usually distal and posterior, as opposed to that someone who is older than 7 years is proximal and anterior. Now, also the way you would drill these tunnels, you're just not going to go as a blind tunnel, you're going to create sockets. The idea of this socket is that you're not going to violate the physis and you're not going to come in from the opposite side. So you're going to angle the drill distally and anteriorly. So you're going to come distally and anteriorly and create a socket, and then you're going to fix your graft. You can also do a quads tendon graft. I personally don't have any experience in this, but the medial part of the quads tendon is stripped off. You then take it and turn it distally and medially, and you fix it by means of a soft tissue fixation below the epiphysis. If you want to do a procedure proximal to the physis, you can do the adductor sling, wherein it is passed deep in through the adductor tendon, and you're going to go ahead and fix this. So that's your adductor tendon. You're going to pass the tendon around the tendon and fix it. Now the issue with fixations distal and proximal to the physis, biomechanically what happens? Now the procedures distal to the physis, the graft loosens in flexion and is more isometric till mid-flexion. And that's what we heard previously also, that it's probably biomechanically till mid-flexion, some amount of isometricity is there, but effectively later on it becomes more or less anisometric. Now, if you look at the procedures proximal to the epiphysis, the graft tightens in flexion, is more anisometric, can result in stiffness, pain, eventually graft stretching and graft failure. So if you compare the ligament isometricity, whether you're looking at a proximal and distal technique, the proximal techniques are definitely more anisometric, but this is something more like a biomechanical study rather than a clinical study. So in conclusion, a type 1A, type 2A, and type B are best treated with an MPFL surgery, and all epiphyseal technique would probably show better isometry. Fluoroscopy guided drilling is useful, rather is mandatory to prevent any kind of physeal injury. First fix the femur and then dock the patella, and associated pathologies may require later correction. It's not that you've done the procedure at that point of time and you're finished or you're taken care of the case in totality. Thank you.